I wonder if we should start so we can get the webinars sort of scheduled for an hour. So just good afternoon, good morning, everyone, wherever you are. My name's Ashley Chin. I'm a cardiologist, electrophysiologist in Cape Town, South Africa, and I'm joined today by two experts. First of all, Professor Chris McLeod is a cardiologist, electrophysiologist, and associate professor at the Mayo Clinic in Florida, and he's an expert in varying aspects. Especially, he's interested in adult congenital heart disease, but he's quite a generalist in terms of general EP as well. So, thanks, Chris, for agreeing to moderate the inaugural AFRA webinar that we're hosting, and then. Muzahir Tabji he's well known to us all. He'll be presenting the second case at 5:30, and he's from Leeds University in the United Kingdom. So welcome everyone. This is our first EP webinar, and we really wanted to showcase some interesting EP cases. So it's really going to be case based, and we plan to hold these webinars on sort of a monthly basis on the first Wednesday of every month. The sort of the format will be 15 minutes or so of presenting, and then some comments from Chris and maybe Muzahir, and then we'll open it up for discussion for another 10-15 minutes or so till about half the hour, and then we'll move on to the second case. So I hope you find this case interesting, and yeah, I'll kick off. All right, so this is a lady I saw about 2 years ago in our clinic here in Cape Town. She came to us referred by a general practitioner. She was a 24-year-old woman who presented with palpitations. She was complaining of some odd skip beats, no real sustained palpitations in keeping with sustained ventricular tachycardia, and was troubled by it. At the time, her GP had started on a low dose of bisoprolol, 2.5 milligrams, and then was referred on to us. Besides that, she gave no history of syncope. There was no on the history, no family history of underlying cardiac disease. There was no history of particular ARVC and no history of sudden death in any first-degree relatives. She was otherwise well. Of particular note was that she was quite an active endurance runner, as a lot of South Africans are. She was, participating in a lot of half marathons, running sort of on a daily basis. So there was quite a strong endurance history to her, in a presentation. And this was an ECG on coming to see me. And what is the striking abnormality here is that this lady was having sort of quite frequent premature ventricular complexes, or PVCs. You can see them over here. And looking at a little bit more at the sort of the morphology of the PVCs, they had a sort of like a atypical left bundle branch block morphology, with a transition here in lead V3, and with an inferior axis. So it was positive in AVF. It was also positive in lead 2. So this was sort of an outflow tract PVC. You can see also the width of the Curis complex. There was no notching. It wasn't very wide, suggesting a septal origin. So my original impression was that this lady was possibly having, right ventricular outflow tract PVCs. They seemed to be occurring quite frequently. They were coming from the outflow tract. The site, because of the V3 transition, I thought that possibly it could be in the RVOT, possibly in the left ventricular outflow tract, but it looked like more like on the right side based on the V3 transition. And I'll come back to that in a moment. So what we did was, initially we started off by doing a 24-hour Holter. This was on, I think, bisoprolol 2.5 milligrams. You can see here on the top here, this is so just to calculate a PVC burden. So the PVC burden was in fact quite high. Her total PVC burden was in a 24-hour period was about 37%, and those were about 33,000 PVCs over a 24-hour period. Most of them were occurring in isolated beats. What was surprising was that when we did a routine echo at a first presentation, was that because the concern here was possibly, did she, with this high burden, was she at risk for an underlying PVC contraction-induced cardiomyopathy. And in fact, her LV function, the report came back from the echo lab, in fact, that her LV function, both the systolic and diastolic function was preserved. She had sort of borderline LV size. She was a small lady, and I thought that might be as a result maybe of the PVCs or possibly due to athletic history. She had no underlying significant valve pathology, but of concern was that her right ventricle was dilated in all dimensions, and further RV imaging was advised. So an MRI, cardiac MRI was advised, and this took me a little bit by surprise because I wasn't quite sure how to interpret this. I mean, we had a young lady here. I thought the PVCs were in keeping with possibly outflow tract idiopathic PVCs. So what was a bit surprising was that when her echo came back, was that in fact her right ventricle showed quite marked dilatation with some borderline LV size. So the initial impression was possibly that this lady had, maybe an underlying athletic heart. The differential included, could it be some athlete's heart? Could it be possibly early arrhythmogenic right ventricular cardiomyopathy? Just looking at an ECG again, there were no other features on the ECG that would suggest ARVC. There was some borderline T-wave abnormalities in V2, but an inverted T-wave in V1, but no other T-wave inversion. So what I opted to do was initially just to ask her to detrain. So she had 2 MRIs, and I'm just going to show you, for the interest of time, the second MRI. I'll just show you the report from the second MRI. So this was after 3 months of detraining on bisoprolol. I kept on bisoprolol 2.5 milligrams. And after detraining for about 3 months, what you can see here from the brief MRI report, and I'm just going to show you, for the interest of time, just the summary, she had persistently elevated right ventricular volumes. So despite detraining, her RV volumes were still above the upper limit of normal. It was 111 mils per square meter, which was, in the upper limit should be about 102. So this would fulfill a criteria for ARVC, although there was comment that she didn't have any underlying aneurysm, she didn't have any wall motion abnormalities. It was just really dilated, and then there was no underlying scarring in the ventricle, both in the right or the left. So the MRI again just proved what the echo showed, was that even after a period of detraining, the right ventricle continued to be enlarged, continued to be big. So at this stage, the question was, I don't think this was an athletic adaptation anymore, and the concern here was that, with this lady, she had, markedly elevated RV volumes, frequent PVCs. She didn't quite fulfill the criteria for ARVC. So my working diagnosis at this stage was this lady having an idiopathic right ventricular outflow tract PVCs, and we just having, as a right ventricle maybe on the basis of the PVCs itself, or was it an early form of ARVC? So at that stage, we also sent off her genetic testing for ARVC. So, just a table here to show you the features that we typically use to help us decide whether someone maybe has features of an RV, outflow tract VT, compared to ARVC. So she didn't have a genetic or family history of cardiac disease. We were awaiting the genetic studies at that time. The symptoms were a little bit unhelpful in that she complained of PVCs, but no sustained VT. Her ECG was quite bland at baseline, which would favor an idiopathic RV outflow tract VT. But again, what was a bit odd was that her imaging, both MRI after detraining, showed elevated RV volumes, and that would be against RV outflow tract VT, because usually they would have structurally normal hearts. We didn't do any biopsies we didn't do a biopsy on her because she didn't have any invasive testing at the time. Her morphology of a VT suggested an outflow tract origin. There was sort of a single type of VT which would favor outflow tract VT. There was a single morphology. So again, there was some, she had features a little bit of both, but most of the features were in keeping with RV outflow tract VT. So at this stage, we decided to opt for an EP study because she was still having symptoms. She had this dilated right ventricle, and the decision was then, because of her symptoms, we decided to try and attempt to go and ablate her PVC. So we took her to the EP lab, and fortunately, on the day of the EP testing, for those who do lots of PVCs, the first thing is that you hope and pray that she has lots of PVCs. And fortunately, this lady did. All right. So she came in, uh, uh, we did it under conscious sedation, not under general anesthesia, just to increase our chances of having the PVCs. And she was having frequent clinical PVCs. If you look at the morphology of the PVCs, it still had this outfit tract morphology. Interestingly, in V2, and it might just be, where we position the leads, it looked a little bit more positive than it did in the original 12-lead ECG. So the transition is still in V3, but the initial upstroke or the R wave in V2 does look a little bit more prominent here, which sometimes favors more of a left ventricular outfit tract origin. But fortunately, she had frequent PVCs. My approach to PVC ablation is that we perform activation mapping. In this case, it was before we had the Octaray. So we in fact did activation mapping with the Pentaray using CARTO. I typically put in a coronary sinus catheter and sometimes an RV lead. I don't think we had an RV lead here, and we went straight up with because she was having frequent PVCs. We went up with the Pentaray. So this is an activation map of let me see if it plays, of the right ventricle or in the right ventricular outfit tract. This is the local activation times here. So for those who are not familiar with local activation mapping, using the confidence software of CARTO, we take a reference QRS complex. This was with the Pentaray, and basically we can acquire multiple points with this multi-electrode mapping catheter, and basically the early sites will appear as red, and over here I've marked the His here. These are the two yellow balls, and what you can see here, sorry, let me just go back, was that the early sites appeared here in the the anteroseptal region of the right ventricular outfit tract, just superior to the His region. There was quite a broad area of red, and looking at the sites on the Pentaray, we never really got a very early site. They were sort of on time in this region, and because there was a large area of early activation over the site, we decided to go and look on the left side, which I think and this is let me see if I can play this. And this is the activation map this is the aorta. This is the cusp over here. This is below the aortic valve over here. And I'm hoping what you can see here was another area of this also was an area of early activation, which was corresponded in the right coronary cusp. Now, when we were in this place, it did look earlier. The earlier sites did look early compared to the right ventricular outfit tract. And when we put it on, if I simultaneously put on the aorta and the right ventricle, you can see that the earlier breakout points does in fact occur here in the right coronary cusp. And you can see the activation map. You can see the breakout point from the right cusp and then proceeds to the right ventricular outfit tract. So we were dealing here with an early site, not on the right ventricular outfit tract, but in fact in the right coronary cusp. And that would keep in keeping with that ECG. So at this site, so we took up I think it was a DF thermocool irrigation catheter, and at the site of earliest activation in the right coronary cusp, this is the point that we got. So this is the ablation distal over here. You can see we were about 41 milliseconds earlier than the QRS complex, so a nice early site. And this is the ablation unipolar here, and it did sort of have a QS pattern in the unipolar signal. So we thought that this was a good position in the right side. We did do a pre-coronary angiogram of the right coronary artery just to make sure that we were far away from the ostium of the right coronary. And then at that location here, in fact, with the first ablation, we were quite fortunate enough to get suppression and termination with the first burn. And those other balls, were just sort of some insurance burns. So here's an ablation. We came on here. She was having frequent bigeminy at the time. And with the ablation on here, we were quite fortunate in terminating the PVCs. So she didn't have PVCs overnight and on discharge. And when I saw her 2 months post-successful PVCs, we repeated a Holter. And unfortunately, she had no PVCs on a follow-up Holter. I was very interested to look at what would happen to her right ventricular volumes, because her RV volumes were quite elevated at pre-ablation. And what you can see here, this is I think 3 months post-ablation, you can see normalization of the right ventricular volume. So right ventricle shrunk from 119 mils per meter squared to 99. So everything came back and came back into with normal limits. So it was an interesting case because it is a case of idiopathic right coronary cusp PVCs resulting in resulting in dilatation of the right ventricle, mimicking an ARVC sort of phenotype, but landed up being a typical garden variety aortic cusp PVC case. So I thought the teaching points for this case for me were sometimes the precise localization of outflow tract PVCs on an ECG with a V3 transition can be challenging because, as I said before, with a V3 transition with atypical left bundle branch block morphology, you can sometimes be dealing with either a right ventricular outflow tract PVC or an aortic cusp PVC. So just the juniors on the call, just to remind you about the anatomy of the right ventricular outflow tract and its relationship to the aortic cusps. And what you can see here, this is a nice review paper that was recently published. The right ventricular outflow tract is anterior in the chest, and the more anterior you are, the more later the transition becomes in terms of the PVC. So you can see here a right ventricular outflow tract free wall PVC. It typically has a transition later than V3, so typically in V4 to V6. And the more posteriorly you then go from there, the more the Curious complexes become positive in V1 and V2. And that makes perfect sense because the V1 and V2 it lies over the front of the chest wall. So as you go more posteriorly, the initial vector will be anterior, going towards the anterior of V1, V2 chest leads. And the difficulty lies here when you're dealing with right ventricular outflow tract anteroseptal PVCs and the right coronary cusp, because you can see here the anatomy, they sort of almost overlie one another. And that's the difficulty here, because sometimes a PVC arising from there versus there can be indistinguishable on the surface 12-lead ECG. So bear in mind that sometimes the anteroseptal and the right coronary cusp PVCs can have a V3 transition and look pretty much the same. The left coronary cusp PVCs tend to have a more positive, they tend to be more positive in V2 from experience. And then as you progress more posteriorly here to the mitral valve, the Curious complexes become positive in V1. So yeah, so that's just a useful review article for those that want to know more about that. This was an interesting article that I found on, it's been published a few years back, and they actually did there's a subsequent paper looking at, there's been numerous algorithms written about V3 transition and what's the best algorithm to try and work out whether something is on the right versus something on the left. This one apparently is the one that's been shown in the study to be a little bit more accurate than the others. And what you do here is that you take the PVC and you measure the R waves in the PVC in V1, V2, V3, and you add them all up. So that's D plus E plus F. And you divide that by the sum of the R wave in the conducted Curious complexes. So that will be A, B, and C. And they worked out that if it's over 0.9, it suggests a left ventricular outflow tract origin. And in our case here, I've just done the maths. You can see that in the PVC, the measurement came out to be 13, and we divided by the R wave sum in the Curious complex, and that was 11. So that came up to 1.2. So if you use this algorithm, it would suggest that that the PVC was going to be on the left side in the right cusp rather than the right ventricular outflow tract. Some other teaching points. Just remember that PVCs can arise from the aortic cusps. They comprise about 15% of all outflow tract PVCs, so much less common than the right ventricular outflow tract, but they do occur there. The left cusp is more common than the right cusp, and that's more common than what they call the left cusp or right cusp junction. But the non-coronary cusp is actually quite rare. So I think there have been some case reports written about that, but PVCs arising from that region is very unlikely. And just remember why that is the case. Why do PVCs arise from the cusp? Well, this is a nice autopsy, pathological study that was shown that if you do a histology of this region, you can see that that there is myocardium that extends up beyond what they call the ventricular atrial junction. So this area here has, or this area over here has muscle fibers that are extending up from the ventricles, and that's why you can get PVCs arising from that particular area. Some teaching points about ablation of PVCs in the aortic cusps. They tend to have unique challenges. One, because they I think some pointers here, you can look for the QS signal, which is the unipolar signal, looking for the QS signal because it's implying that the depolarization is proceeding immediately away from the tip of the ablation catheter. But it can be seen over a wide area. So again, that can sometimes let you down. Pace mapping, we didn't do pace mapping in this patient. I find it quite unreliable in the cusps, very good for the in the right ventricle, but I find it less useful in the left because sometimes you might not be able to capture the ventricles consistently there. There might be far field capture. So pace mapping tends to be a bit less reliable. I tend to use an irrigated catheter, but you must need to be careful here, and that you need to go quite low. I burned here 20 watts and then sort of ramped up to 25 watts. I think some ablations go up to 40 watts, but I think you just need to be careful there because you were burning quite close to the coronary arteries, and you need to stay at least 5 millimeters away from the coronary ostia. Some people have access to ice, you can use that to determine the distance, or as in our case, we actually elected to put a catheter in the right coronary. And lastly, the teaching point from this case, I found it was an interesting case because the idiopathic PVCs here didn't really cause a PVC cardiomyopathy involving the left ventricle, but seemed to cause transient, well, not transient, but persistent RV dilatation. And that was, I think, something new to me, and I must have didn't know that. And, again, you're never the first to report that because I went to the literature, and in fact, there's been a case report here of exactly that, an isolated PVC-induced right ventricular dysfunction mimicking ARVC. So there's a case report similar to ours, a patient who had frequent PVCs, and in fact presented with an isolated right ventricular cardiomyopathy that fulfilled, they say, major criteria for ARVC. They then went on to ablate the PVCs, and in fact the right ventricular cardiomyopathy completely resolved, confirming the diagnosis that this was, as a result of the PVCs and not due to underlying structural heart disease. So, and the theory behind that is that, possibly in some patients with very high counts, there's marked mechanical and electrical dyssynchrony of the right ventricle, and possibly that could lead to dilatation of the right ventricle. So I think for those who, it was new to me, but I think that's something that I also learned from this case, which I found interesting. So that's my last slide, and we'll open it up now for discussion. I'll be interested to hear what Chris and Musa here think about the case, and then we can open it up to the audience for any questions that you might have. Thanks very much.